Good evening, everyone. And thank you so much, Estefanía Rodríguez, the doctor joining us this evening from Vida Fertility, as we're discussing a really important topic, the problem of low response to IVF, which I know can be really heartbreaking for anybody who goes through it. As always, big thank you to My IVF Answers and the European Fertility Society for making these events possible, because it's completely free and an opportunity for you to ask your questions directly as we dive deeper into these in-depth topics that I know can be so confusing for people. So before we get into this, and incidentally, for those of you who submitted questions in advance, please know that we will be getting to all the questions at the end of our discussion, and you can also submit questions into the question box as we go through this as well. So be sure to pop in your questions there, because I'm sure there'll be lots to get through. So yeah, before we dive in to everybody's questions on that side of things, it's probably best to start with an overview so people can actually understand the definition of a poor response with IVF, because of course things have changed between the Bologna and the Poseidon criteria, and it's not exactly a perfected science, is it, in terms of defining it yet?
Yes, thank you for the invitation. I'm very happy to be here and talk about this topic because this is very important. This is the present of reproduction techniques. All day we have low responders. And what finally in the practice, what is a low responder? It's a woman that we want to stimulate, and finally we can't stimulate a good quantity of eggs. That's finally the low responder. We have some woman that comes with a low ovarian reserve, and that's the factor that produce the low response. Or other woman that they come with a good ovarian reserve with the studies, with the test that we have already done, but finally after the stimulation we don't have a good quantity, a minimum, the quantity that we thought that we were going to stimulate. That's a little bit the problem.
Yes, so you've got on the one side those that you might expect, maybe based on low AMH, high FSH, that they might not have as many, but then there can be the surprise cases where they seem like they should be okay, or their antral follicle count is looking good, but then when it actually comes to the cycle itself, they're not getting enough eggs. And at your clinic, at Vida Fertility, what would you define as enough eggs?
Well, that depends on the case. Okay. That depends also of many other factors because of the quality of eggs finally. Okay. Because if we have a young woman, maybe with a low quantity of eggs, we can try to have more embryos. That depends also of the main factor, but we are going to talk about the low responders. And with more eggs, in other women we need more eggs. In a woman with 40 years or with more than 35, 38 years, maybe we need more. Or in a case that we have a low quality of eggs, maybe we will need more to get a minimum of embryos, okay, to get pregnant. And those are the factors, the quality and the quantity.
So for someone who's watching and sort of wondering, where do I fall in that category? Let's say for a woman under 35, let's say 25 to 35 years old, would it be workable that they're getting 3-4 eggs? Is that still enough to proceed with the cycle rather than it being converted to a triggered cycle instead?
With less than 35 years and to have a good opportunity to get a baby at the end, I think we usually say that 8 eggs to have more than 50% of having a live birth. Finally, that's with less than 35. Okay, that depends on the male factor, but
of course,
in general,
as well.
yes,
so that makes complete sense. But I suppose what I'm also interested in for people is, because I've seen this with clients where people have been told, oh, you have less than 6 eggs, so we think you should cancel the cycle, but you can go ahead if you want to. So
yes. Yes, that depends on the quantity that we think we are going to get. Okay, if we have the first stimulation in a woman, and we with the with the ultrasound we control and we have less than 8x, we can talk about that. Okay,
Yes.
this is the situation. We think that maybe your response is lower than expect, so we can continue, or we can stop this cycle and change and try to improve. Okay, that's a little bit. But if we expect less, we will have to talk about the quantity of eggs that we expect.
And of course, I suppose it's important to clarify the difference between, someone might appear to have, let's say, the threshold of 8 eggs, but when it comes to the retrieval, how many of them are mature,
yes,
and how many of them can then fertilize. So I presume that can be an issue in cases where there's that drop off and they get lower numbers.
Yes, because we have cases that we have a good quantity of follicles that they grow, and then at the end we can get a lower quantity. Maybe some follicles they are not with an egg, and that can happen. And today we have talked about that in the clinic because of a case. So that's a problem. We have to try to control all the factors, but at the end is the last day, the day that we can see the quantity of eggs.
Yes. And then for how many fertilize after that, there's just so many things at each point. So it's the initial hurdle for people to get over is just the numbers of eggs. So on that note, because I've seen this come up for some cases, and for somebody who's maybe looking for, well, what might my risk factors be? Like, how would I know if maybe I might be that type of person? Would you see a history of earlier menopause in the mothers of women who might have poor ovarian reserve at a younger age?
Yes.
Yes. Okay.
Yes.
Yeah.
We always have to ask questions about the parents, the mother. We have to know the antecedent. If the hormones they are low, we have to know if there are some factors. The first factor that we have to study if there is a low response, a low ovarian reserve, is the genetical factor. Okay, we have to check the karyotype. We have to check the X fragile. That's another genetical yes disease. And we have to check those things, because if there is a problem there, maybe we have to go to a PGTM and study something more.
So let's just rewind a little bit for those who aren't familiar. So with the karyotyping, obviously blood testing for partners to really to see, that essentially counting chromosomes, make sure there's no genetic conditions there that would be a problem. The same with the Fragile X, and then the PGTM, pre-implantation genetic testing for sort of morphological criteria, or monogenic, where you're looking at specific criteria that might be coming through from, or PGTSR as well.
PGTSR, yes.
So just explain that, because I literally had that conversation with clients the other day who were so confused. They've been speaking to a Spanish clinic, and I think in Spain, you guys are a bit ahead, definitely, than what I've seen in Ireland and the UK. So having all this choice for PGT, people are like, wow, what does this mean? PGTA, PGTM, PGTSR. So just to clarify that for people, essentially dependent on what's coming back through testing, certain types of genetic testing for your embryos may be more beneficial or not. So
we can give more information about the embryos. This is all the information that we can get nowadays. We can't get more information. If there is a problem, we in some cases we recommend directly to go to the PGTA. That's the general study of the genetic of the embryos, and then if there is another disease or a thing, different kind of studies.
Absolutely, and also just to put it in people's minds and understanding. With low ovarian reserve or poor response during IVF, which can be sort of two sides of the same coin, the assumption is often, oh, well, it's probably somebody over 40. They're the people you'd expect to have it. But of course, there are, younger women who maybe have gone through cancer treatment or maybe have autoimmune conditions. So could we discuss that a little bit more as to the kind of categories of person that you might see in this situation?
Yes, we can have a young woman less than 35 years that they have a normal studies, that they have the hormones and the ultrasound, they are normal. And then when we start with the stimulation, we get less than 3, 4 eggs. Okay,
Right.
this we have to evaluate what kind of stimulation we have done. That's what we usually do. Okay, and maybe change the hormones that we have used. Okay, there are many studies that tell maybe with only FSH, that's the first hormone that we are going to use to stimulate. Maybe we have to increase or add the LH, another hormone, okay, to try to improve the response. Okay.
Yes.
And with that, there are low ovarian responders. Okay, in this category. Okay. We can have low ovarian reserve woman, a young woman. Then we have the first thing to study genetical part. So we have talked about that.
Yeah.
And then maybe other factors like endometriosis,
Yeah.
or other factors that can produce a low quantity of eggs, maybe surgeries or other factors, okay, that can produce.
So let's unpack that, because there's two really important things you brought up there. First, the protocol and how important that is. And I'd love to get into that and talk about things like duostim. But then also on the other side, what you were saying just about the amount of eggs that they'd get at the end of it. So let's break it down. So with the protocols, which do you favor the duostim in clinic? Is that something that you do?
Yes. We can use that, because if we have a low quantity of eggs, maybe with that we can, in a very short time, we can get more eggs into cycles. Yes.
So just to explain that to people who aren't aware, because I know from clients in certainly Ireland and the UK, they're not as frequently offered a duostim protocol. It's a newer option. Just to explain a bit about how it's 2 recruitments of eggs within the same cycle. So it's actually quite efficient, isn't it? Yeah.
Yes, that depends a little bit of the case of the woman also. But yes, we start the first cycle, the first stimulation, the same that always we have done. Okay. And then when we have already take all the eggs, then we wait 5 days and we start
again
a second time. Okay.
Yeah. So just for anyone who's confused, so you're not having to fly back home and then go back for another cycle. You're doing 2 in 1, essentially. Yeah.
Yes.
Hence duostim. Yeah. Okay.
Yes. That in some cases I've seen, and we have seen that in the second part of the cycle, in some cases we can get more eggs. The quality of eggs is the same. Okay. In many studies published that the result, the quality of embryos that we can get is the same. But we can't do a transfer in those cycles. Okay, we have to vitrify the eggs, the embryos or the eggs.
They have to be frozen.
Yes.
And certainly I've looked a lot at the research for that, because obviously people traveling from Ireland are a little bit suspicious or nervous of, why would I do duostim? But from what I can tell in the literature, with a number of meta-analysis studies, it first of all is safe, from all the studies. It also is efficient. And while, yes, exactly as you said, you're not getting any extra benefit in terms of the quality of the embryos, it can be very helpful for people who are nervous about their low ovarian reserve, because they can get those 2 recruitments rather than having to do consecutive cycles. So I think it can work well for people from what I've seen. Sure.
Yes.
And then to go back to the endometriosis and the autoimmune side and surgery on the ovaries, because this is huge. So I'm sure this will come up in the questions, because I often get asked this. So I'd love to hear your take on it. If somebody has an endometrioma, which is, is an endometriosis type cyst on the ovary. And obviously in certain cases, it might be quite large and there might be recommendation to remove it. But then the concern is, if I have surgery on my ovary, is that going to reduce my AMH level, my ovarian reserve? So how do you guys weigh that up in clinic? I presume there's factors to consider, like the age of the woman as to whether she should have the surgery first or to go for egg retrieval first.
We, the reproduction specialist, we always recommend to stimulate before the surgery first.
Okay.
Yes,
Okay.
that's always our recommendation. That depends on the on some factors like size, or if there is many pain or something like that. Okay, but if we can, we try to stimulate before. Okay, because the surgery is going to reduce the quantity of eggs. Okay, we can do a totally a perfect surgery. Okay, but we are going to touch the ovarian reserve. Okay, so if we nowadays we are quite we try not to touch a lot the ovaries. Okay, if the cyst is not quite big, we try not to remove. Okay,
leave the cyst alone if it's not going to be a big problem.
Less than 6 centimeters nowadays, we try to wait. Okay, that's what that depends on the symptoms and other things, and we are going to control. Okay, the size, but if we can, and we are going to recommend, if women don't want to get pregnant, a treatment. Okay, hormones to try to control the size, or to reduce in some cases the size without surgery. But if the size is more than 6 centimeters, there are some risks about complications. So we recommend to start to go to surgery. Yes.
To go to surgery in those cases. Yeah, absolutely.
Yes.
If it's too large. Because from what I've seen in the literature, for those who have undergone surgery and they needed to have it done on the ovaries, and maybe they couldn't wait because of their symptoms or whatever might have been going on, while there's a drop off or a decline in the AMH, it does seem to recover after about 6 to 12 months. So, you know, for younger women, I totally understand. For somebody over 40, it's like, no, let's just go in and get the eggs. But if someone is really struggling with symptoms, you know, there might be an argument for potentially going ahead with surgery, even if there is a decline in AMH, because it can recover.
Yes, the recovery can be better with young women. Okay.
Yes, exactly. Yeah.
With age is less frequent, but
it's riskier. Yeah, for sure.
We try to do all in the time. Yes.
And speaking of that, speaking of age and what people can do, because, you know, we'll get into all the questions now in a second, but if someone finds themselves in that position where they've gone through maybe multiple, I would have thought at least one cycle, has to be more than one, to really get a gauge of somebody's ovarian response, in case there was just one poor response, but then it recovered. But let's say it's 2 or more cycles and it's just not working. What are the recommendations that you would give for maybe treatments or investigations they could look at to support or boost the egg's development before resorting to egg donation?
I always talk with the patients about egg donation in the cases I inform, and I tell that they have to think that they have done all they can to go to egg donation. Okay, if you don't think that, maybe we have to talk about the options. Okay, but in some cases we can recommend some kind of treatment that they are under investigation. Okay, ovarian PRP, for example. Okay, that we can introduce. The PRP is taken by the same blood, okay, of the patient, and we are going to produce. We are going to take a part of the blood to introduce into the ovaries. Okay, that is done before the stimulation program. Okay, and we, in some cases, we can do it between 2 cycles. Okay, so we are going to do it in the same moment that we are going to extract the first quantity of eggs. Okay, so to try to improve and to try to decrease the risks. Okay, for that stimulation. That depends a little bit of the cases, and we have to explain always that the quality of eggs is not going to improve. Okay, the PRP in some cases can improve the response, is
The
100%
responsiveness,
based investigation, but not the quality of eggs. Okay.
And just for if anybody's looking that up, because I know it's sometimes called ovarian rejuvenation as opposed to PRP,
Yes,
which is platelet reduced plasma. So just so people are aware, and you're working with your own blood product. So there's no outside, medication interference, which is why it's considered pretty safe, albeit, it can have mixed results. Of course, it's not a guarantee that it's going to boost, the responsiveness of the ovaries. So how effective have you seen PRP being with your clients?
That depends a lot of the cases. Okay, I think nowadays we are trying to get information about which are the cases where we can introduce this treatment to really improve. Okay, so we are looking for that kind of patients, but now we don't have all the information about that. So in young woman, in women with a low response, that we think that they can respond better, okay, we are going to try this kind of treatment. Yes.
Okay, so it's generally PRP would be offered to those of a younger age category in your clinic?
Yes,
Okay.
less than 38. We can talk about it if there is not a contraindication for the treatment, but yes, I've tried in women with more age, and if you have a very very low ovarian reserve, it doesn't increase. That depends of the size of the ovaries also. So yes.
Yeah, there's a number of factors, and it is very individualized, so that's important to state. And exactly as you said, there's not just the eggs to consider, there's also the sperm and the male factor. So we've got a lot of things happening at once. So I think I'm actually going to move to the questions, because I can see there's lots of them in the list. So thank you so much to everybody who submitted questions, both in advance and are popping them in now. So I'm going to bring up the first one here now onto the screen, because it's quite long. So I want to make sure you take a look and read this person's case. So this woman writes, last round was double luteal phase, I presume duostim. First got no embryos, a second got 2 that slowed growth and didn't make it to day 5. We used Perjuvera and Enlova stims. In Lomba. Yeah, I think it's in Lomba in Spain. Should we stay with the same stimulation? It improved on the second cycle. 40 years old, low AMH, BMI 30 to 31. One last chance now. Had prior cycles that were similar, slow sperm, so was used similar, so used Pixie to select the sperm. Want to do Zymot or Max, other sperm selection techniques. Can HGH, human growth hormone, help to get more follicles? Should IGF-1 blood testing be done first? Can HBOT therapy help? Hyperbaric oxygen treatment? And can PRP help? Need as many good follicles for the last chance. Wow. Okay, so there's a lot of things to unpack.
Yes, many information. Okay. Here we have many factors that we were talking about them for low ovarian response. Okay.
I'll remind you of them as we go through.
Yes, yes. We have the age factor 40 years. Okay.
40,
we have the low AMH, I think. Yes. We have the IMC also, okay. With more, we have low ovarian response, okay, because we have a top with the quantity of hormone that we can give, okay. I can't give a dosage, double the dosage, to try to improve the response, okay. So it's difficult to try to respond more. All the treatment, the growth hormone, the PRP, the oxygen therapy, I have never used that. So
that's popular in Ireland.
Yes, I don't have that practice, but they are. There are some studies that they tell they can improve the response, but there are no recommendations in general to use them directly for that. So I have used the growth hormone. I have never have a very good response with that. Okay, we have already used that, and with the PRP in very low quantity of cases. I think that we have to know which cases, but in that case, with 40 years, I don't think so.
Yeah, in
Yes.
terms of it being beneficial. And it's really important to say this. And thank you for your honesty on that point, because I totally understand that when someone is in that situation, they're grasping at everything. Of course, you do anything you could to try to make a
Yes.
difference. But you have to be so careful of being sold things that are just spending a lot of money and not necessarily getting a return on your investment. Now, for myself personally, I have had clients who were 40 and older, like up to about 44, who did actually do well with PRP. But it was a very, it's potluck. In other words, it could be 50-50. Some people, nothing happens at all, so your money's wasted. Others, they might see just a little bit of an improvement
Yes.
for the subsequent 1 or 2 cycles. So it's a difficult one to say. And from what I've seen in the literature on HBOT, hyperbaric oxygen treatment, I'm not convinced. I haven't seen enough in the literature specifically to sperm, which I know it's been told for the partners to use it as well, and also for the egg quality. There's nothing wrong with it, I suppose, assuming you've no contraindications, ear problems, problems with pressure on the ears. But I certainly haven't seen any amazing outcomes with it.
With PRP, we have here a college in North Spain. I've published a recent study about that, and they get 1 egg more in the group of women that use the PRP. So.
Yeah, I know it's not much. I suppose though, for a woman who's over 40, you might get 1 egg or 2 eggs. That could be a huge difference.
Yes,
but it's going to be an individual decision for sure.
An individual
for sure.
Yes.
Brilliant. That was a great answer. I'm just going to bring up this other long question, so we'll see. And thank you for all the detail, everybody, because I know there's a lot to get through. So this person's 41, AMH at 4.5. Now, where's this person based? I'm not sure if it's Ireland or Spain, because obviously I appreciate the different measurements for the AMH. So female hormone profile was fine. Periods were regular, but on the day of the scan, very low follicle count, 2 in one ovary, 1 on the other. So the consultant questioned was actually active even, or was that ovary even working essentially? 1 round of IVF, long cycle, poor response. Cycle was stopped as only 1 follicle active and maturing. I'm on all the supplements. I bet you are. Quite healthy. Didn't feel menopausal. Don't know what else I can do. Starting 1 last cycle in January, a short cycle. And if that doesn't show a good response, they have advised to think about donor eggs. However, I would really like to use my own eggs, and I'm already using a sperm donor. So is there anything else I can try? Well, that's tough.
Yes, low ovarian response, 41 years. That's the problem here. That depends. I think that we have to try to get the better response with the hormones that we can use, FSH, LH. What does she can do? Maybe she continue with a diet, the Mediterranean diet that we tell to control the IMC. Okay, to continue with the vitamins, but if she takes a variety of diet, a Mediterranean diet, it's not quite obligatory that, okay, the folic acid and those things, and not many more, okay, to get a better response.
I completely agree. And all I would add to that is, just because sometimes it's what's not said in the question. So I suppose I would also, given you've heard us talking about endometriosis and the impact that can have, any secondary health conditions, and I don't just mean endometriosis, but any background history of autoimmunity, such as Hashimoto's thyroiditis, because that can affect the ovaries, any problems with IBD, so ulcerative colitis or Crohn's, anything that could affect absorption of nutrients, anything chronic. I have definitely seen that in cases like this where seemingly everything is okay reproductively, but you're being frustrated. So yeah, I would look into that side as well. But yeah, really tough for that person's case. So sorry. Next one here. Do the experts think that Mounjaro, the weight loss injection, would have an effect on egg quality and poor responders to IVF stimulation? Can this drug affect AMH or FSH levels, as so many clients are using this drug to get their BMI down to get IVF funding? there's some small amounts of research coming out that using weight loss drugs at certain times in the IVF process could be beneficial. If clients take this drug without medical supervision, could this cause problems? And I can guess your answer to that.
Well, we are nowadays with this kind of questions. Yes, what we know nowadays is that it doesn't change the quality of eggs. We use it a lot now because we want to improve the response. Okay, and we want to improve the result with this kind of patients with BMA high. Okay, so we use it a lot, and we think that they are quite sure, okay, that we can use it, but with a control, okay, because the objective is to low to improve the result, but not to how to do. We try to continue with the diet and with the active, the sport, and to do a good quality of life. Okay,
Yes.
all the pregnancy along. Okay, because we want to improve the all the life. Okay, not only
Completely.
to lose weight. Okay.
Yes, well said. It's not
Help.
just about, it's to add to the whole overall biochemical picture. It's not as simple as the visual, how someone presents in terms of their body size. It's what's actually happening internally, like with insulin resistance. So to add to that, just because I was listening to an interview with some doctors talking about longevity medicine recently, and it was just quite interesting because they were talking about, Ozempic and Mounjaro. And the bottom line, which I think is so important from what you said here, number one, medical supervision, very necessary, very, very necessary. Number two, exactly what you were saying, Estefanía, about the importance of everything else alongside. So we know there's a big problem for people who take these medications and don't make the diet changes, and most importantly, the resistance training, so they don't lose the lean muscle mass. That's really, really important. But that said, if well managed and done appropriately, there's some evidence now coming out leaning towards it supporting longevity, which of course fertility falls into that bucket when you're talking about things like insulin resistance, even if it's not directly affecting the eggs. So it's an interesting one, but I'd say we're probably a few years away from having enough research on it. So another big one here. Sorry, they've all been long questions, but hopefully you'll be able to help this person. There we go. So I've had 6 or 7 timed sexual intercourse cycles in the past year, 40 years old, have one biological son, now age 7, conceived on my first attempt, and now I've been trying to conceive over 5 years. I'm so sorry. I've been diagnosed with premature ovarian insufficiency. AMH is 0.07. FSH and LH are sky high. I do have an overactive thyroid. With Dr. Luda, this is a doctor in Ireland, who was the only doctor willing to try to get me to conceive with my own eggs. No activity on my left ovary, but I have one follicle on the right that grew to the correct size each time. But when I take the trigger shot and do everything to a T, so do everything perfectly, there is a negative result. It hasn't worked so far. Do I just go for the donor egg at this stage? I miss the babies I should have had by now. Do I just go for it? Wow.
Yes, I'm sorry about the problem, but that's the first thing that we have to tell, that to pass to egg donation, we have to be convinced. We have to think that we have done all we can. Okay, and that with the egg donation we can get the better result, the better probability of a good result. Okay, so in some cases that's the key to get the result. Okay, we have cases that they want to try last time, and they want to try all. So in these cases I usually use the PRP, the ovarian PRP, but with no, I can't tell that the result is going to be sure better than the previous ones.
I think in this one's case as well, just given what you described, trying for 5 years to have a second baby, so that's from 35 until 40. you had every reason to believe that it should happen given you conceived your son. And I think in these cases, what I would probably be advising is, particularly for any of the clients I've seen, I'm sure you've seen this in clinic too, when someone already has their own biological child, it's a much harder decision to move to egg donation.
Yes, that's
and
true.
So, it's very different. I've seen people go through egg donation and then they have the same donor for a sibling and they're quite happy with that. But when you already have a child, it is going to mean having those tougher conversations in the future. And if you haven't already been offered it, please make sure that you get proper counseling and proper support with making a decision. Because it almost sounds like in her question, do I just go for it? Like she's asking us to give her permission to go for egg donation. So to go. So it does sound like you're at the end of your tether, and I can understand after this many years trying. But you're going to have that conversation with your partner, get counseling, make sure that you feel that you've been given enough information, the ramifications of this, what it might mean medically speaking, let's say in the future for the health of that second child, if not genetically related, so it's just really important that you go through all of that. But have I seen those situations and people are happy at the end of it? Yes, I have.
Yes.
I'm sure you have too.
Yes, many cases. Yes, that depends of the objective, the family that you want to have finally.
It does. And how many children? That's very, very true. Yes. So best of luck to that woman. I'm just going to read this one out because we have a short one here for change. If diagnosed with genuine empty follicle syndrome, what are the options? What can you do?
I'm sorry, but I haven't understand.
Sorry, if a person was diagnosed with true or genuine empty follicle syndrome, when a person
empty follicle syndrome. Sorry, yes, I understand that. Yes, if that can happen because in one stimulation we haven't get any eggs, okay?
Yes.
And that we have seen the follicles, but finally we don't have after distraction the eggs, okay? We have to check all the factors that we have in that case, the hormones, do respond, many things to be sure, okay? What we try to do is to repeat, to check really that's the diagnostic.
I would agree.
Because in some cases that depends on the trigger that we have taken. Well, that depends on many factors, the cycle in some cases, but in some others it's quite sure that you have we have here a problem that we don't have the eggs inside, okay? That I've read some studies about that. They tell that many in some that we think about the genetical problem there, okay? And that's why the eggs they are not there, or they can't be.
They're not there. Yes, absolutely. Almost like azoospermia for a man. Kind of.
Yes, that's the point. So we nowadays we don't have a treatment to improve that. Okay, we don't have anything. I have had some cases that we have repeat 2-3 times the stimulation. At the end, we have some egg. Okay, but it's quite difficult to improve. There is no treatment directly for that.
Yes, completely. And I know this person emphasized genuine empty follicle syndrome. So I'm, presuming they have had the checks or repeated cycles.
Yes.
But I would just emphasize what you were saying about the nuance and how important it is to be individualized with the protocol. Because I've seen problems like this where, maybe the trigger that was used or the timing of the egg retrieval, or maybe they weren't responding well to the orgalutran or cetrotide. So they were kind of ovulating early and things got, so just make sure that you're working with a clinic and consultant where they really seem curious and interested to figure things out for sure. I think that's so important. Perfect. Next one here. And thank you guys for all the questions. This person writes, AMH 1.2, stage 3 endometriosis. What are the other options instead of HRT? And gives the name of the hormones, estrogen and progesterone, priming for low responders. I got 17, 11 mature, 10 fertilized. one euploid, genetically normal, PGTA normal, and one low-level PGTA, so I presume mosaic, that must be, one low-level and a 4C untested. Was on Perjuveris and Gonal F. I got 14, 11 mature, 10 fertilized, still in progress, high DNA frag using the ICSI and the Zymot. Also had 3 pregnancy losses and had excision surgery before retrieval. So sorry, do you want to get some water there, and I'll deal with this. It's okay, don't worry. So I'll just take this for a second while Estefanía sorts herself out. And sorry, I'll bring it back here so you can see me, so you're not just staring at a blank screen. Now, let me go down to this question. Right, so the other options instead of the HT for low responders. Now, I would say this, with 17, 11 mature, 10 fertilizing, that's not bad at all. And statistically speaking, so 10 fertilized, I'm not sure how many made it to actually day 5 or day 6 for biopsy for euploid testing, but getting a euploid normal, like healthy embryo, which means less than 20% cell damage from that, is really, really good. Like that's great to have achieved that within those numbers. And then you noted one low-level PGTA, I'm presuming low-level, so mosaic would be less than 50% cell damage. I assume that's what you're referring to there. And then the 4C that was untested. So typically if you're talking about the embryo grading and testing, the number at the start just tells you the stage of development of the blastocyst, whether it's early or expanding or expanded or hatching. And then the first letter is the inner cell mass that refers to the baby, and the second letter is what would become the placenta. So if you have a C grading for the first letter, they don't usually want to do the PGTA biopsy, or they don't think it's likely to be good embryo because that's a much lower grading for what would become the baby. And now that Estefanía is back, she can take over. Not at all. You're fine. You're absolutely fine.
So, you have had 3 embryos in the first cycle.
Yes.
That's
yeah.
That's good.
The euploid, low-level PGTA, and then the 4C untested.
Yes, the first one is the better for sure, and the mosaic it can be transferred also. Okay, a little bit more. Yes, and if you are with the second cycle, that's good. Okay, the kind of hormones that they are using, the FSH with LH also. Okay, that's good. I don't know the age. I think that she hasn't
doesn't mention age, I don't think. No, just low AMH and stage 3 endometriosis.
And I think that was also a male factor, I think.
Yes, so there was a high DNA fragmentation, so that's why they're using ICSI and the Zymot because of prior pregnancy loss as well.
So I think you are in a good cycle with the quantity of eggs that you have fertilized. You don't have a low response finally, but that depends on the quality of eggs or the quality of sperm. And we have between 40 and 60% of blastocyst of embryo in day 5, 6. So that's not very low.
Yeah. No, it's good. And I think as well, it's important to say you got a euploid before, so you could get a euploid again. So, I'm sure there's that precedent. If you've managed to achieve it, then you could achieve it again. And also just to add, because I would do a lot of work with people dealing with pregnancy loss, given what you've gone through, because you mentioned the 3 losses before, please, please, please don't proceed with transferring a precious euploid embryo until all investigations have been done for the internal environment as well, especially with that history of endometriosis, just because it's a bit heartbreaking if somebody transfers a euploid and still suffers a pregnancy loss because of overlooked immune issues or blood clotting issues or problems with the internal environment or whatever it might be. So just take your time with that. But yeah, best of luck. I hope it definitely works out for you. We've got another longer one here. I'm just going to bring this up. I'm 46, been doing IVF for the last 7 years, had 14 plus egg collections and 12 transfers. Wow. AMH 2.1 PMOL, I usually make about 3 to 4 eggs and get 1 to 2 blastocysts, which is actually very good. Our clinic is now in Greece, but I've had 3 attempts with them, but no success. Previously in UK, I had a miscarriage at 8 weeks. This is the furthest we've ever got, and got to see the fetal poles on both embryos. We have male factor and my older age. That's it. My clinic are now talking about egg donation. We never tested our embryos, or donor embryos, I should say. We never tested our embryos in UK or Greece due to low numbers. We just transferred what we got. What do you think? So yeah, there's a lot going on for that lady.
Long history.
Yeah,
Yes.
I know. I'm trying to break it down.
In this moment, what we usually talk with more than 43 years is that the quantity of embryos that you can have with euploidy is very, very low. So if we don't have many eggs, it's quite difficult to get a good embryo. Okay, so we don't have the that's true that we don't have the result of the genetic of your embryos, but many of them they have the genetic alteration. So it's I think we can recommend or think about the egg donation, but and we have to take care about the age for the uterus also, because with more than 45 years we know, and we have more and more information about the problem that we can have, and lower proportion of implantation rates. So try to decide now to get a better result with the egg donation also.
I would also say, because she said we never tested our embryos in UK or Greece due to the low numbers. I've seen clients who only had 1 embryo and they still did the PGTA. And I think in a case like this, being, into mid to late 40s, that would make sense. Even if there's only 1 embryo, I would consider biopsying it. And if you're not getting any more embryos, then yes, of course, looking to the egg donation. But exactly what Estefanía was saying about the implantation, again, this kind of goes back to it's the same principle. Even if you're using donor eggs, I would still do PGTA of the embryos to make sure that you know what you're transferring, and then make sure to check the internal environment, because there's so many factors. I mean, as you all know, in terms of the communication between the embryo and the endometrium. There's a lot there that can go wrong. So you want to be trying to maximize that as much as possible, make sure that the due diligence is done. Before transferring. So yeah, tough case. Okay, another short one here, to be easier for you. Is there any specific protocol for women over 40 with premature ovarian insufficiency that has got good results? So clear question.
No, a specific protocol. that depends on. We have that's true that nowadays with a low ovarian reserve, nowadays we don't use a higher dosage of hormones.
I was just gonna say.
We're going to talk about that.
You read my mind.
yes, before many years ago, there's the dosage. Lower ovarian reserve, more hormones. And we had some problems about that, because in some cases we didn't have a response. So nowadays we try to decrease the dosage, to try to improve the if there are 2-3 eggs, we're going to give the minimum to get the result. Because with more we are not going to get more. So nowadays there are some protocols with oral pills also, not only injections, and with 1 day the injection, another day we don't give the injection. But we try to optimize the quantity of
softer
hormones.
Yes.
It's like more natural, because
which is going back to what the original IVF was, if you think about it, because I think that was something that I really saw shifting over the last decade or so. I think back in Celtic Tiger times, as in within Ireland in the early 2000s, where there was a lot of money and a lot of everything being done with fertility, and it's like, let's just give tons of drugs, just give them the more the better.
More the better, yes.
It wasn't working. You
It's
weren't seeing any better outcomes. So why put somebody at the risk with giving them high dose stimulation meds if you're not getting any better outcome? And yeah, I've really tuned into a lot of the research on the sort of the IVF light and, using
yes.
lower, much more nuanced doses. So I love that you brought that up because, yeah, I've definitely seen that working.
Yes, and we get good result with that.
Yes,
I'm sure I use
exactly.
that every day. Yes.
Yeah, no, for sure. That's very important to say. Another short enough question here. Why is my left ovary the main side ovulating? My left tube is blocked. Oh, this poor woman. So
yes.
follicle count is, one or two. Clomid gave me 3 follicles on the left. Is that a good response? So there's the response to the Clomid, and then there's the problem with the left ovary being dominant.
Yes, that can happen with the ovaries. 1 or 2. I'm not sure is that in a insemination program or a fecundation program. I don't know.
It sounds like ovulation induction program,
ovulation
maybe.
induction. I think maybe
the eggs will go to the other tube on the right side that isn't blocked.
Yes, the maximum that we try to stimulate with that kind of programs is for me, I try to get 2. Okay, 2 follicles. To improve a little bit the proportion, but not to improve a lot the twins. Okay.
Exactly. You don't have risk of multiple pregnancy.
Yes. But the maximum is 3. That depends of the age. That depends of other factors. And if you have repeat, then they are negative before. But multiple pregnancy is a risk there. So
it is, although I suppose her concern is that they're coming more from the left side, so there'd be less chance because you have to have transmigration of the egg to the other tube. True, but at the same time, yeah, I wouldn't say, when you're asking is it a good response, it's fine. It's to get 3 follicles as opposed to 1 or 2, but I'd say this, and I'd imagine you'd probably agree, I wouldn't want somebody in this situation to continue on Clomid or letrozole for very long. I mean, if you have a blocked tube and that ovary is the busy ovary, how many cycles are you going to do that for before it's like, listen, IVF is much more likely to give you success,
Yes. We always try to try to get the cycle that we can stimulate the ovary, that we have the tube, but in some cases it's not possible. That happens, and we try and we get pregnancies, but how many times we are going to repeat that? Yes,
you don't want to do that for months on end. So a longer one here I'll just bring up. At 40 years old, AMH of 5 with an almost 4-year-old naturally conceived child, 2 unsuccessful IVF cycles this year with only 4 eggs on one cycle and 1 egg on the next cycle. Is it possible to improve the response? I've tried long and short protocol. Is there anything that can be done differently? The clinic has recommended donor eggs, or to do the same short IVF protocol again, but only got 1 egg. Clinic says my eggs are poor quality and my age is the problem. I'm devastated. That is very, very tough.
The quality is the point here with the age. To improve, we can change the protocol, as we said, but the quality we can't change that. So that's quite difficult. And if you have tried, there are many cases with many stimulation programs and different kind of stimulation. It's quite difficult to improve.
It is. I really empathize, given, again, this is like that other case, because only 40, and has a 4-year-old. So again, that situation of having your firstborn and like, what's going on? Why can't I just add to my family? It's a really tough situation. So I'd say, going back to what I said earlier, the importance of, anything that's outside of the picture that you shared with us, to make sure to fully investigate that, to see if there's any way that could play into, for example, in the literature, we know that those with who do shift work, for example, that can impact their egg quality. I actually had a doctor before as a client, and she knew herself because of her shifts that she was working, this is not good. And she had to try and take a 3-month sabbatical to avoid that. So anything that you can control yourself, like I said, looking at secondary health conditions, medications you might have been taking, making sure that everything really is on point with your hormones and nutrient levels, everything you can control, basically, outside of being 40 years old and the AMH. And, potentially that would give a better outcome, because I really understand not wanting to move to egg donation yet, given your particular history. So yeah, I really hope you can get a better outcome. Okay, we've got time for just a couple more questions. Okay, so have we looked at this one yet? No, I don't think so, right? This is another longer one. Bear with me. 4 cycles. First was cancelled due to poor response. Second, we got 5 eggs, 3 fertilizing, 1 embryo. It didn't work out. Third, got 8 eggs, 5 fertilized, 1 embryo. That also I don't think worked out, or then failed FET, so that didn't work out. Fourth, abroad, 3 eggs, 2 fertilized, no embryo. Clinic advised donor, but AMH is not low. Working with restorative doctor now since April, who has put me on, I presume, low dose naltrexone for the endometriosis, Plaquenil, prednisolone for high natural killer cells. Want to do an egg retrieval before a laparoscopy. Do you recommend Duostim? And if so, what drugs? Have heard low responders don't do well with Pergoveris. Love to know your thoughts on a good protocol for slow responders.
Yes, finally Duostim is to try to get in the same cycle 2 times. Okay.
Yeah.
I used a lot Pergoveris with this kind of woman, and I have good experience with Pergoveris. Okay, in some cases no, but and we have to change the stimulation hormones, but I have good result. Okay, not a very high dosage that we have tell. Okay, I usually with a low ovarian reserve I use 150 of Pergoveris, not more. Okay.
Not more.
But we have I have good result, and with the the Duostim, it can retrieve more eggs in the same cycle. Yes.
So really, it's about going for the Duostim in this person's case.
Yes.
Yes, I would say so.
It can be if you want to try last, and you have all the factors that you have studied, and they are controlled now. Okay.
Yes.
So that's a point. Maybe with the PGTA, if you can do that, I don't know, but to try to transfer the best one. That's
because I don't see age. I mean, she mentions about the cycles.
No,
but I didn't see age.
No.
And the other thing I'd say is timeline, because she mentioned working with the restorative doctor since April. Okay, we're now in November. And the low dose naltrexone for the endo, Plaquenil, prednisolone, high natural killer cells. So one thing I would say is, we know the eggs don't really like developing in a very inflammatory environment.
Yes.
So if you have been working on this, just be mindful of the timeline, that the folliculogenesis takes 90 to 120 days, because I've seen this borne out so many times, where the vital 3 to 4 months after your markers have normalized, that's when you start to see better outcome with the eggs and better outcome with the cycle you're going through. So just be conscious of your timeline there, because it might not just be about only the protocol and the timing, because you've been through a lot, with 4 cycles. It could be the combination of the Duostim, but also timing things once you've got the endo picture and the immune side under control as well. Because I'm sure you must see that a lot. The kind of, you're bridging that gap between all the different things going on.
Yes,
it's a lot. All the factors. And then I'm just trying to get to questions that haven't been covered. Well, a simple one here. Somebody asks the efficacy of CoQ10, so biquinone or biquinol, for, I presume, for the low responders.
Yes, there are studies that they tell they can improve the. There are protocols with vitamins. There are some kind of vitamin mix that we can try. Okay, it can't improve the quality, the genetical quality, okay, but it's recommend to improve the environment of the eggs finally, okay. In some cases we can see an improvement, in some others not, but it's not a bad question to take. Yes.
Yeah, there's nothing. I mean, I'd always weigh up side effects, pros versus cons.
Side effects.
There's certainly not a downside to taking
yes.
Yeah, there's no problem. Specifically now with CoQ10, of course, it is possible to take too high levels of certain antioxidants, puts you in that problem. But also to note, exactly as you were describing, it's, if you think of the egg, it has essentially battery packs. It needs a lot of energy to push forwards that early stage of blastocyst development. And that's often one of the main things that suffers with the mitochondrial function. So that's where your ubiquinol, as in CoQ10, or NAD in the form of NMN, all these new things that are coming online can be helpful with that. But exactly as you said, it's not, the actual fundamental risk of aneuploidy. It can't fix that.
No, but that's good.
But it can help. Help.
It can help.
Yeah, it definitely can. So if we have time for, I'm going to do one last one because we're on minute to finish. Can premature progesterone rising impact embryo quality in IVF? I had a premature rise of progesterone on both ICSI cycles prior to egg collection. So that is an interesting one.
That's a good question. But nowadays we stimulate with a high progesterone level in the second part of cycle. So yes, we can think that if before this traction we have a high level, and that's produced because the ovulation protocol is coming, okay, that you have increased not the quality. We maybe can have the risk of lose some egg, okay, if the increase of progesterone is quite high, okay, it's low, no, that's not the problem. But nowadays we use the progesterone to reduce the risk of a peak with the LH. We use the second part of cycle to stimulate, and we have a higher quantity of progesterone in blood. So we don't think so.
Yeah, it doesn't seem to affect the outcome, because like you said, you're getting potentially the same, if not more, eggs in the luteal part of the duostem. Yeah, and still getting embryos. Yeah, I would say, I'm just trying to think of cases that I've seen. If you're talking about when it comes to the transfer of the embryo, that's obviously different. You don't want levels too high or too low, but certainly the premature rise, it's more about it interfering with the maturation phase of the egg at that point. But like you said, you're not seeing a huge difference, so fingers crossed for this woman that it won't be an issue. But I suppose I would investigate what's going on. I would have question marks over your protocol, why is there the premature rise on two cycles? So I would maybe look into your protocol.
If there are many eggs, or
what's going
on? That depends.
And make sure you're monitored closely. Get your bloods done, get everything checked. Don't let them leave you for too long. So, okay, I'm looking down. There's so many other great questions. I know we could be here all evening. but thank you so much, Dr. Estefanía. I really appreciate it. I loved, just being able to dive into this topic and hopefully help people a little bit at a time where it is very, very difficult. It's a very stressful experience to go through with poor ovarian response, and you're trying everything you possibly can, as so many people said there in their questions, the A to Z of supplements and the A to Z of every intervention. That's why it's so heartbreaking, because we really would do anything. So are there any parting words of wisdom or tips or encouragement you would give to somebody who finds themselves in this situation?
Yes, try to talk with your specialist always, to tell all the information that you have about your all day things. I don't know how to tell that to
your daily activities,
with the menstrual pain, all the things,
all your symptoms.
Yes, for us that's very, very important to try to get the key, or to know the factors that can improve your result, and to try to improve the stimulation programs. Okay. And if in the first cycle is a problem, we have to try to get all the information about the cycle to improve those results. Okay. And all the treatment that we can try, the PRP and the other treatment, that depends on its case. We can recommend and try in some cases.
I think that is very sound advice, to make sure that, you know, exactly as you said, that nothing is left on the table, that you've given all the information you possibly can, that everything has been attempted, as you were alluding to earlier, before making that suggestion of egg donation, because it's so important that somebody gets through this, whether an individual or a couple, and they're not left feeling regret. You know, we might not get the outcome that we want, but just at least being given a fair try. I think that's the most anybody could hope for. So thank you so much. Where can people find more information about Vida Fertility?
Yes, you have a lot of information in the internet, Vida Fertility. And we have nowadays 2 clinics in Spain, in Madrid and Alicante. And we will have another one next year in the north, in San Sebastian.
Brilliant. So what's the website for anybody who might be looking?
Vidafertility.com.
Vidafertility.com. Perfect.
Yes.
Perfect. Nice and easy. And from my side, I'm obviously Jessica Bourke, the Fertility Detective. You can find me at the Fertility Detective on Instagram. That's usually where I'm, you know, talking, posting, and also answering a lot of DMs, because I know the difference it can make to somebody's day. If I just spend 1 minute answering something like we were doing this evening, it can hopefully make this journey feel a little bit less lonely. So if you need help with programs or one-to-one, you can check me out there. And for now, I'll let you go enjoy your evening, Dr. Estefanía. Thank you. It was an absolute pleasure.
Thank you very much. A pleasure for
me. I really appreciate it. Thank you so much. And I'll see you all again for the next event that we have coming up in, I think, 2 weeks' time. We're trying to fit them in a bit quicker before Christmas, because otherwise people will be busy. So thank you so much. And as always, if there's anyone who wants to get in contact with either Dr. Estefanía or myself, you can reach out with your questions, because I appreciate we couldn't get to them all this evening. But thank you so much to my IVF and European Fertility Society, as always, for hosting these. Have a great evening.
Good night.
Take care. Bye-bye.
Welcome.